Hi, this is Stephen, and in this video we will discuss how to assess a stiff mitral valve or mitral stenosis with echocardiography. And so let's take a look at our parasternal long axis view. We've got the mitral valve, the left atrium, that empties into the left ventricle. You've got your aortic valve here, and we'll give a little bit of thickness to our left ventricle. And you've got your right ventricle up here. All right, and what are the common causes of mitral stenosis? So some of the common causes would be congenital mitral valve disease, rheumatic, and that's actually what I've drawn. We'll get into that in a second. Or like a degenerative that you'll see in an older person with a lot of calcium, degenerative. And what are some of the things we can see on the parasternal long axis view when we look at the mitral valve? Well, we can look and see, is the leaflet moving well, or is the tip not moving so well, or maybe part of the valve is not moving well, or maybe the whole leaflet is not moving well. We can grade the motion of the leaflet. We can see whether there is thickening just at the tip of the leaflet, or through the mid leaflet, or all of the leaflet. They're thickening. We can see if there's calcification, and again, we can grade it based on if there's just some calcification at the tip or if there's calcification all the way through. And then we can look at the subvalvular apparatus. Right here, the chordae, the papillary muscles. We can see if there's thickening on just part of it, or we can see if the whole subvalvular apparatus is thickening and retracted. And so we can use those. To define a Wilkin score. And basically, the higher that score, the more dangerous ballooning open the stiff mitral valve would be, because you may tear it. So if the valve if it's thickened all the way, it's calcified, it's not moving at all, and even the subvalvular apparatus is all thickened and retracted, that would be a very high Wilkin score, and then that would mean that your ballooning it would be higher risk. One other point that I'll just mention here is that the valve I've drawn here with this kind of it's called a hockey stick or a dog leg shape. This usually you see in rheumatic mitral valve disease. All right, so that's how we can look at the valve and get a sense as to how successful a ballooning procedure would be. But how do we quantify how stiff the valve is beyond just looking at it? Well, there's a couple different methods. Let's scroll down a bit here. The first is we can look in the parasternal short view, where this would be the left ventricle. And you've got your right ventricle somewhere up over there, shading in the left ventricle. And if you can get to the smallest opening of the mitral valve, you can actually just trace it. Keep in mind, if you're slicing at the wrong angle or at the wrong level, you will overestimate the mitral valve area. But you can use two-dimensional planimetry, or if you have 3D echo, three-dimensional planimetry as an estimate. What are some other methods? Well, let's go to our apical four-chamber view. So you've got your mitral valve here. Your left atrium empties via your mitral valve into your left ventricle. Over here, you've got your RV, tricuspid valve, and right atrium. And we can take our continuous Doppler and measure the flow of blood coming in. And what might we see? Well, first let me draw normal, and then let me draw what you'll see with a stiff valve. So normally, during diastole, you'll see early inflow, and then you'll see some late inflow, the E wave and A wave. E and A. And then systole, you won't see anything. And then again, in diastole, you'll see E wave, A wave, something like that. What will you see with a stiff valve? Well, you'll see that blood flow actually, instead of a nicely defined E and A wave, you'll see something like this. And actually, I'm just going to shade these in since it's with continuous Doppler. The question is, what does this mean? And the way I think about this, why do you have blood flow that is continuing to take a long time? It starts going from the left atrium to the left ventricle and it keeps going. Why does blood keep flowing across? Well, it keeps flowing because there's an ongoing gradient between the left atrium and the left ventricle. There's an ongoing gradient which leads to ongoing flow because it doesn't appropriately quickly. The left ventricle does not appropriately quickly fill. It's slowly filling, but there's an ongoing pressure gradient that drives that ongoing flow. And we can actually use this to quantify. So if you were to trace this out all the way to here, this is the deceleration time. Deceleration time. And if you take 0.29, we'll call that dt. 0.29 times the deceleration time, that is the pressure half time, PHT, pressure half time. Or that's the time that the pressure halves. So the pressure goes from 25 to 15 or 10 to 5. The time that the pressure goes to half its original value. And you can remember that we said pressure equals 4v squared, so you could do a little math to figure out what the velocity, it's not that the velocity will be half, but you can calculate what the ratio of velocity would be. But you measure this deceleration time, 0.29 times the deceleration time is your pressure half time, and then you can say 220 divided by pressure half time. That is an empirically derived estimate of mitral valve area. Not based on physics, just based on a bunch of scans that people did, and they compared what the area actually was versus the pressure half time and found that this relationship tends to hold. Now, I'll mention right after you do a procedure to the mitral valve, like if you balloon a stiff valve open or there's other procedures, then this is less accurate. But in a stable system where there's not rapid changes to the valve and to the hemodynamics, then this can be used. So that's how we estimate the valve area with pressure half time. Of course, we could also just take the area under here, and we could get a mean gradient from that. Mean pressure gradient. I'll draw a line to denote mean pressure gradient. And so what would be severe? Well, severe would correspond to a mitral valve area, a certain mitral valve area, a certain mean pressure gradient, and a certain pressure half time. It would correspond to a mitral valve area of less than 1.5 centimeters squared. It would correspond to a pressure half time of 150, and if you do the math of 220 divided by 150, that's about 1.5. So those two add up. Or if you're looking at the mean pressure gradient, the mean pressure gradient would be 10 millimeters of mercury. Now keep in mind that your mean pressure gradient does vary quite a bit as your heart rate changes. Why? As heart rate changes, systolic time is relatively preserved, but diastolic time can greatly shorten. And the less time you give for blood to fill the left ventricle, the higher your gradient's going to go. Right? 4v squared, the higher the velocity, the higher the pressure. All right, so that's severe mitral stenosis. I just want to make one other point. You may recall from previous videos that we can also calculate or estimate our mitral valve area with the proximal isovelocity surface area concept, or with the conservation of mass. And I'll refer you to our other videos that go through some detailed examples on these. But again, just to recap all of this with the stenotic or stiff mitral valve, typically from congenital heart disease, rheumatic heart disease, or degenerative valvular disease. Rheumatic, you'll see that dog-leg appearance, and you can grade and give it a Wilkin score to determine how likely you are to succeed with balloon valvotomy. And then we can quantify, we could just trace out the valve area in short axis, but often we'll use the pressure half time, the flatter, that the flatter, this line right here on the graph. The flatter this is, the worse. But 0.29 times the deceleration time will give you your pressure half time. 220 divided by that is an empirically derived way to estimate the valve area. You can also just look at the mean gradient, or you can use some of the other methods we talked about, PISA or conservation of mass. If the valve area is less than 1.5 centimeters squared, which would correspond to a pressure half time of 150, or if the mean gradient is 10 millimeters of mercury or higher, then you have a severely stiff mitral valve.